Hello everyone, my name is Seung-Hyup Kim, Professor of Radiology, Seoul National University Hospital. In this session, I would like to talk on imaging evaluation of Müllerian duct anomalies. To understand Müllerian duct anomalies, we need to understand the development of normal female genital tract. This video publicized on internet well illustrates the process. The process begins with development of pronephros and its duct. Then mesonephros appears and grows with regression of pronephros. Then ureters appear from urogenital sinus and grow upwards with development of metanephros, which is a future kidney structure. And the gonads appear and grow. Then paramesonephric or Müllerian ducts appear bilaterally and grows downwards. And the fusion of Müllerian ducts occurs behind the bladder, forming uterus, vagina, and fallopian tubes, and the gonads move downwards next to fimbriae of fallopian tube. Again, you see development, fusion, and septal regression of Müllerian ducts in this video. Uterovaginal anomalies may result from failure of any stages of development, fusion, or septal regression of Müllerian ducts, and associated fallopian tube and ovarian anomalies are rare, but renal anomalies are commonly associated with Müllerian duct anomalies. Reported prevalence of Müllerian duct anomaly is variable, but generally thought to be 1 to 3%. Patients with Müllerian duct anomaly have reproductive problem in 25%, and symptoms depends on presence of functioning endometrium and endometriosis. Well-known and most commonly used classification system for Müllerian duct anomaly is ASRM classification system. Here ASRM stands for American Society of Reproductive Medicine, that is now American Fertility Society. This classification system has 7 categories. Category 1, hypoplasia agenesis, 2, unicornate uterus, 3, didelphys, 4, bicornuate uterus, 5, septate uterus, 6, arcuate uterus, and 7, drug diethylstilbestrol related. But this classification system has limitations because with this system it is difficult to describe complex or combined anomalies. Vaginal malformations are not included. Length of septum or depth of fundal indentation is not defined clearly, which is important in differentiation among septate, bicornuate, and arcuate uterus. And adnexal or other malformations are not included. Because of these limitations, various other classification systems have been developed. One of those alternative classification is VCUAM classification. Here, V is vagina, C cervix, U uterus, A adnexa, and M associated malformations. This VCUAM system describes each genital organ individually, similar to TNM classification of tumor, and this table is a detail of the system. Here is an example of Müllerian duct anomaly. You see widely separated uterine horns with deep indentation between them, and single cervix and a single vagina. So this is a bicornuate uterus at ASRM classification, but we can describe VCUAM system like this way. In evaluating Müllerian duct anomalies, ultrasound is usually the initial study, but MRI will be the study of choice because it shows detailed elaboration of uterovaginal anatomy and so has high accuracy in anomaly classification. Here is a case of both ultrasound and MRI show two separate uterus, cervix, and vagina. Hysterosalpingography is a basic imaging test for infertility workup, and it best shows uterine cavity and tubal patency. Limitation of hysterosalpingography is that uterine outer contour is not visible, so rudimentary horn will not be identified if its cavity is not communicated with the main uterine cavity. If we push and pull the cervix holding tenaculum after peritoneal spill, the outer surface of the uterus may be coated by spilled contrast media like this image. This information of outer uterine surface is an important point in differential diagnosis of Mullerian duct anomalies. Also, hysterosalpingography may miss one of two cervices in duplex cervical canals. This hysterosalpingographic image shows left uterine cavity only, and it looks like a unicornate uterus. But later image after using push and pull technique, outer uterine surface looks bilaterally symmetric, and so we might have missed another uterine cervix on the right side. Ultrasound and T2-weighted MR images well show two uterine bodies and cervices. So we should be careful if hysterosalpingographic findings suggest unicornate uterus, and we should search for another cervix that might have been missed. Ultrasound is the first-line imaging for any gynecologic disease, and we may use transabdominal ultrasound, transvaginal ultrasound, 3D ultrasound, and sonohysterosalpingography. Ultrasound is accurate in evaluation of Müllerian duct anomaly with accuracy higher than 90%. But ultrasound may not demonstrate some important findings in Müllerian duct anomalies, such as type and extent of septum in septate uterus, associated vaginal anomalies, rudimentary uterine horns, and endometriotic implants. MRI is the best imaging modality to evaluate Müllerian duct anomaly because it has excellent soft tissue contrast, especially T2-weighted imaging, and also has multiplanar capability. Basic pulse sequences are T1 and T2-weighted images. Contrast enhancement is not a must, but may provide additional information that may be sometimes quite helpful. MRI usually shows contour of uterine fundus, which is very important, and reported accuracy of diagnosis of Müllerian duct anomaly is almost 100%, and so articles say that it may replace diagnostic laparoscopy. Let's begin with ASRM class 1, hypoplasia and agenesis. This anomaly is due to failed development and migration of Müllerian ducts. It is accompanied by variable degree of vaginal agenesis with shallow vaginal dimple. Uterus and cervix are absent or very small, and ovaries are normal. In case of agenesis, you do not see uterus, but you may see solid soft tissues on both sides adjacent to ovaries, which represent remnant Müllerian tissues, as you see in these yellow circled areas. Here is another case of Müllerian duct agenesis. There is no uterus, no cervix, and no vagina. You see normal ovaries, green arrows, and Müllerian remnants, yellow arrows. MRKH syndrome, or Mayer-Rokitansky-Kuster-Hauser syndrome, is basically a syndrome of Müllerian duct agenesis, so uterus, cervix, and proximal vagina are absent. These are full names of those four scientists. There are two types of MRKH syndrome. Type 1 is isolated Müllerian duct agenesis, and type 2 is agenesis associated with tubo-ovarian, renal, skeletal, spine, and cardiac anomalies. Here is another case of Mullerian duct agenesis, and you see Müllerian remnants on both sides connected by fibrous band-like tissue, like this schema in this article. In sagittal imagery, you may see small triangular soft tissue in the midline, which is probably a remnant uterine tissue. Also, you may see thin, low-intensity line, which is probably remnant fibrous tissue along the course of vagina. Urinary tract was normal in this patient, and this patient does not have any other associated anomalies, so this is a case of MRKH syndrome type 1. Here is another case of type 1 MRKH showing the same findings: triangular midlines of tissue, absent vagina, and Müllerian remnants with connecting fibrous band-like tissue, and normal ovaries. This is another case of MRKH syndrome. Midline triangular structure is more prominent than previous cases, and it has a shape of small uterus. So this case belongs to MRKH syndrome, but uterus is severely hypoplastic instead of agenesis. So we may call this case as MRKH type 1 variant. Here is another case of MRKH variant. In this case, instead of Müllerian agenesis, there is a rudimentary uterine horn on the right side without connection to cervix and vagina. Another case of MRKH variant. Here you see rudimentary horn of uterus on right side, red circle and arrows, Müllerian remnants, yellow arrows, no cervix, no vagina, and normal ovaries, green arrows. This patient has skeletal anomalies, so this case belongs to type 2 MRKH. This case is also a variant of MRKH. There are findings of adenomyosis in rudimentary uterine horn on the right side, no cervix, and no vagina. Mullerian duct anomaly class 2 is unicornate uterus. This anomaly is caused by partial or complete lack of development of Mullerian duct, is commonly associated with renal anomalies on the side of absent or rudimentary horn. Rudimentary horn may be absent, may be present but no cavity. Cavity is present but no communication with uterine cavity, or may have communicating cavity. Cavitary non-communicating horns need to be resected to prevent endometriosis, ectopic pregnancy, and hematometra and/or hemosalpinx. Here is a case of unicornate uterus with cavitary non-communicating rudimentary horn. You see high signal intensity at T1 weighted imaging representing hemorrhage, which is in the rudimentary horn next to the right-sided uterus. The relation between the uterus and the rudimentary horn is well demonstrated at T2 weighted MRI and ultrasound. Another case of unicornate uterus with functioning rudimentary horn, which is not connected to the right-sided unicornate uterus. You can see high signal intensity endometrioma at fast-suppressed T1 weighted imaging, which shows T2 shading as you see in the red circle, and you can see left-sided rudimentary horn in yellow circle area. This is a gross morphology of removed rudimentary horn. Class 3 anomaly is uterus didelphys caused by failed fusion of right and left Müllerian ducts. In this anomaly, we can see widely divergent symmetric uterine horns, no communication between cavities, and separate cervices. These findings are well demonstrated at hysterosalpingography and MRI. This is a case of uterine didelphys with multiple uterine myomas. This patient also had urinary tract anomaly, left kidney agenesis. This is another case of uterine didelphys and adenomyosis, more severe on the left side. In this patient, only right-sided uterus was opacified at hysterosalpingography. HWW syndrome, or Herrlin-Werner-Wunderlich syndrome, is a variant of uterine didelphys. Components of this syndrome are uterine didelphys, obstructed hemivagina, and ipsilateral renal agenesis. That is why it is also called OVIRA, or HVIRA syndrome, which stands for obstructed hemivagina and ipsilateral renal anomaly. This is a case of HWW syndrome having uterine didelphys, obstruction of right vagina with hematocolpometra, and right renal agenesis. Here is another case of HWW syndrome, and you see uterine didelphys, left-sided hematocolpos, and left renal agenesis. Bicornuate uterus, or ASRM class 4 anomaly, is caused by incomplete fusion of Mullerian ducts. We see two symmetric uterine horns and fundal indentation. There are two types, complete and incomplete types. If there are two cervices, so bicornis, bicollis, it is a complete type, and if there is one cervix, so bicornis, unicollis, it is an incomplete type. Prognosis of pregnancy is generally good in bicornuate uterus. Here is an example of complete type bicornuate uterus. We clearly see deep indentation of outer uterine contour in the fundus and two cervices. Another example of bicornuate uterus, two separate horns, two cervices, and fundal indentation. Septate uterus, or class 5 anomaly, results from failure of resorption of uterovaginal septum. Septum can be complete or partial within the uterine cavity, and it may extend to upper vagina in about 25%. Uterus is normal in size and it has symmetric cavities. Uterine fundus has normal flat or slightly convex outer contour. Septum is usually composed of myometrial tissue proximally and fibrous tissue distally. Here is an example, and we see complete septum from uterine fundus to cervix. This anomaly has poorest reproductive and obstetric outcome, with high risk of spontaneous abortion, about 65%, and premature birth rate, about 20%. Fetal survival rate is approximately 30%. Another case of complete septate uterus with normal urinary tract. This is a case of septate uterus with extension of septum into the vagina. You clearly see a complete septum in the uterus and two separate vaginal cavities. Another case of septate uterus with longitudinal vaginal septum. Hysterosalpingography showed only one uterine cavity with erroneous impression of unicornate uterus. MRI clearly shows complete uterine septum and two cervices and two vaginal cavities separated by longitudinal septum, which is continuous with uterine septum. Differentiation between bicornuate and septate uterus is important because treatment is different. Surgery for bicornuate uterus is done from outside, but uterine septum is removed through hysteroscopic approach. Hysterosalpingographic differentiation is done by using interconal angle. Interconal angle bigger than 105 degree, like right side case, suggests bicornuate uterus, while this angle smaller than 75 degree, like left-sided case, indicates septate uterus. But often this angle is intermediate, so differentiation is difficult, as this case in the middle. For differentiation of these two conditions at MRI, we compare the location of a fundal apex and the interosteal line, which is the line connecting both sides of tubal ostia. If fundal apex locates below this interosteal line, like figure A, or less than 5 mm above this line, like figure B, it is probably a bicornuate uterus. If fundal apex is more than 5 mm above this line, like figure C, it is more likely a septate uterus. This is a case of bicornuate uterus, and this is a septate uterus. Arcuate uterus, or class 6 anomaly, is the mildest form of Mullerian duct anomaly and can be regarded as a mild form of septate uterus. This mild and broad impression on cavity is called saddle deformity. Outer fundal contour is normal. On hysterosalpingography, the height of fundal impression is less than 10% of intercornual distance. Rate of miscarriage is 3 times higher for arcuate uterus compared to general population, and the patient with this anomaly may benefit from metroplasty. Last anomaly, ASRM class 7, is diethyl-stilbestrol related anomaly. Diethyl-stilbestrol is the earliest synthetic form of estrogen and was used widely from 1948 until 1971 to prevent miscarriages. Exposure during the first 5 months of pregnancy may cause uterine anomalies in female offsprings, characterized by hypoplastic uterus and cervix, T-shaped irregular uterine cavity, increased incidence of clear cell adenocarcinoma of vagina and cervix, and increase the risk of spontaneous abortion and premature delivery. Hysterosalpingography best demonstrates these anomalies. There are various causes of congenital vaginal obstruction, including vaginal agenesis, transverse and longitudinal vaginal septum, and imperforate hymen. Longitudinal vaginal septum may or may not be associated with obstruction. This is a case of distal vaginal agenesis, and we see dilated vagina filled with blood at ultrasound and MRI. This patient does not have urinary tract anomaly. This is a patient with transverse vaginal septum with dilated proximal vagina and uterine cavity. This patient does not have urinary tract anomaly, and vaginal obstruction was treated by cruciate incision of vaginal vestibule. This is a case of imperforate hymen with severe hematocolpometra. Another patient with imperforate hymen without urinary tract anomaly, treated by cruciate incision of hymen. In summary, I would say imaging, especially MRI, is imperative in evaluation of patients with Müllerian duct anomaly, and we radiologists should be familiar with the concept of normal and abnormal Müllerian development and their imaging findings to help gynecologists manage these patients.